This conference will now be recorded.
Well, good morning, everyone, and welcome to our Payor Panel. This is one of the most anticipated panels of the conference, and we have got some very impressive leaders of all the major 5 insurance companies with us today. So with that, let me introduce our panel. Dr. Michael Howell is the Regional Medical Executive for the Southeast U.S. for Cigna and the Medical Senior Director representing North and Central Florida and the U.S. Virgin Islands. He's a board certified in internal medicine and a fellow of the American College of Physicians. He earned a master's in business administration degree with a concentration in health management from Keller Graduate School of Management at DeVry University. He is also an assistant professor and faculty member of the Florida State University College of Medicine. Dr. Howell enjoys working with the employer community and provider organizations to establish value-based collaborative relationships and understands well the complexities of population health. Dr. Howell, if you just raise your hand so they know you're there. Thank you.
Good morning.
Michelle Copenhaver is the Vice President and Executive Director of the National Network Strategy Innovation for Aetna Health Plans. She has over 30 years of experience in the healthcare industry, in the clinical realm, as well as a healthcare executive focused on network development. Her experience includes local and national network strategy and management, business development, health system contracting, operational performance, relationship management, and consulting with national accounts and plan sponsors, value-based contracting, and building connectivity to social determinants of health. She is particularly interested in creating personalized healthcare experiences for their members and patients and ensuring positive, progressive relationships with physicians and hospitals, enabling them to perform at their best in value-based and sustainable models of care. Michelle, if you just say hi.
Hello, good morning. Thank you.
Ruth Fricky will be on audio only, and she is the Commercial Vice President for the Southeast region at United Healthcare. In this role, Ruth is responsible for overseeing strategy development, contracting, implementation of services, and the ongoing management of contracted ACOs for United Healthcare in the Southeast region. She also works with the Southeast region network team, facilitating value-based incentive arrangements and various initiatives focused on total cost of care. And Ruth, we're going to wait for you. Dr. Azalea Tim is joining us for the first time on our panel as the Chief of Staff to the Chief Medical Officer of Blue Cross Blue Shield of North Carolina. As Deputy to the Chief Medical Officer, she oversees implementation and execution of Blue Cross North Carolina's value transformation strategy to improve quality, outcomes, and affordability for its 3.9 million members. She is also a primary care physician and faculty at the Duke University School of Medicine. Prior to joining Blue Cross of North Carolina, Dr. Kim served as Medical Director for Population Health Analytics and Applied Health Data Science Strategy for the Duke Health System and its Accountable Care Organization. Dr. Kim also received her MD from Mount Sinai School of Medicine, I believe in New York, an MBA from Harvard Business School, and a Master's of Public Administration from George Washington University. You just wave and say hi, Dr. Kim.
Morning.
And then last but not least, Paul Sapia is the Population Health Strategy Lead for the Office of Population Health for Bold Goal Markets for Humana Health Plans. Paul joined Humana in 2014 and took over the network management for both Duval and Nassau counties. Paul was able to utilize his diverse healthcare background and provider contract experience to build the community PCPs network and enhance the relationship with Humana's MSOs. In early 2016, Paul took the lead for the Bold Goal Initiative for Humana and has taken a hands-on approach for understanding the needs within our community and the organizations that are there to help. Paul also graduated from has a bachelor's degree in exercise and sports management from the University of Florida, and a master's degree in health administration from the University of North Florida. Paul, if you just wave and say hi.
Good morning, everybody. Thank you.
I will tell you, we are quite honored today to have such an incredible panel of skilled and people representing us. So with that, let's jump right into our first question. And I will call on each one of you to go through this question. COVID-19 left no aspect of healthcare unscathed. Because of the sudden changes in the day-to-day practice of healthcare, what types of interventions were necessary to allow providers to maintain stable footing during the initial weeks through current initiatives? And I'll call on Dr. Howell first.
Thank you, Larry. I appreciate being here today. So when the COVID pandemic struck, I think it caught all of us unawares. We hadn't planned for anything as catastrophic as this turned out to be. And the MGMA back in April noted that about 60% of practices just had a sudden decrease in patient volumes, and another 55 or so percent of folks had a total revenue decrease. And we weren't ready for this. Doctors' offices didn't have money in the bank to carry on. And with the amount of furloughs that ended up occurring over the next several weeks to several months, practices were decimated. So one of the major things that practices looked out to payers and other sources of revenue, they were trying to find, where can we get money to keep our doors open? One of the challenges that they had, though, was because there was a lack of equipment, personal protective equipment, they really weren't able to keep their doors open. So, as a payer, and I'll make sure I leave some for everyone else to comment on as well, as a payer, we sought to try to find ways to help them close some of those gaps. Some payers might have tried to offer resources other than what the government was providing. Other payers didn't have that as a resource, but other payers could offer up resources in form of operational lapses, if you will, or operational releases, so that folks could navigate the system with a lot more ease. And then finally, I would tell you that where payers were able, they were able to use some group purchasing contracts to make sure that providers had access to PPE. I mean, that was one of the major things. You can't practice in this environment without having that. So let me just go ahead and let others have a chance to add some content as well. Thanks.
Thank you, Dr. Howell. Michelle?
Yeah, no, such an important piece here. And, first of all, I want to just say a huge thank you to all clinicians, physicians, hospitals, medical assistants, nurse practitioners, radiology, everybody. The work you do every single day for all of us is always incredible. It's always unpredictable, but nothing can compare to what we have endured and faced this year. So big thank you. You deserve any support any of us can give you. I have clinicians in my own family that I worry about every single day. So thank you. And, we've really taken a two-pronged approach in support. Directly with providers, we've expanded our Resources for Living program, which puts our providers in direct connection with community resources and other types of support related to their emotional health. You always are facing tough challenges that most of us cannot even relate to around grief and loss. But now during these times for everyone, mental health and emotional health issues are particularly important. And for those of you on the front lines, it's exponentially greater, even though you have the training in those such things. So also the Resources for Living program offers access to financial guidance, caregiver support, family meals, and all those types of practical things that are needed on a daily basis. We have also expanded telehealth. We always paid our providers the same as they receive for office visits, but we make sure that they're aware of that and continue as more and more of our providers are venturing into that space. Some of you were doing that already. Others are really entering that space for the first time. We want to make sure you understand that we are covering our patient expenses around COVID testing as well as treatment. And we wanted to make sure you had at your fingertips access to some handy information, such as that provided by AMGA and the AMA, regarding safest and most straightforward ways to reopening your practices. So the second approach that I would throw in is you need support through your patients as well. And of course, those are our members. And, we share that. We share that. We want our patients to stay healthy, even during these crazy, scary times. So we have been outreaching on a proactive basis to our membership to make sure that they know that obtaining preventive services is still really important. We don't want them to enter in a situation months from now where they're facing a crisis that could have been abated by receiving proper preventive services. We've been sending care packages to your patients and our members when they've been hospitalized. We've been waiving the requirements that we have around early refills for 90 and 30-day scripts. We've been making sure that home delivery of medications is free. I mean, we want to keep patients adherent and on track during these times. So again, multi-pronged, directly to our providers, and then also through their patients to help them stay healthy, to decrease some of the worry along those lines. So thank you again.
Thank you, Michelle. Ruth?
So yes, good morning, everyone. First of all, I wanted to thank Florida Flaco and also Nicole. I know that on March 20th, she sent an email out to many providers providing some guidance on the CMS telehealth guidelines. And then she also posted a link to each one of us as a payer that in order to be able to provide information. So that was really super invaluable, as far as, capitalizing on the interventions that all of us took as payers. So what United did was we ended up developing a command center, and we did a COVID-19 provider website. We also did a COVID-19 open hours WebEx it was available 8 a.m. to 8 p.m. for providers to go to and ask questions and get responses. And then we also had a SharePoint site that was out there. As far as the intervention, some of the main questions that came from providers early on were telehealth. Do you cover it? How do we bill for it, et cetera? Which, from a United perspective, we had already began engaging our ACOs in the provision of telemedicine visits. So for us, and we were paying as though it was an office visit. So for us, it was pretty simple to just expand that, to other providers that met the necessary criteria and guidelines. Some of the other things that providers were asking for that we had to put forth were a modification in prior authorizations. We also had many questions around credentialing because they felt like providers may leave and then they were going to have to replace them with someone else who may not have been credentialed. They were seeking to understand that they were going to get continued payment. And we really we got a lot of questions and a lot of communication from providers, and it was either through our call centers, our advocates, the contractors, and so forth. And we endeavored to respond to those as quickly as we could, allowing the providers to feel comfortable that we were there for them and that we were supporting them in every way that we possibly could. We also, as y'all are aware, we were chosen by the Department of Health and Human Services to provide $30 billion in emergency funding. So that was another thing that we ended up having to do, and we were very happy to do it. And so when we continue to monitor the impacts, obviously we all know we're not through this yet. I receive a weekly report tracking COVID admissions for all of our lines of business, broken down by state, et cetera. But I think everyone was very surprised at how quickly that we needed to move from day-to-day face-to-face encounters into a much different area in the practice of medicine. And I think we all did a yeoman's job in providing those necessary pathways. So thank you.
Excellent, Ruth. Paul?
So first of all, I want to echo Michelle's comments and thank our providers and the frontline staff for everything that they did. I mean, the work that they did to support the patients, the members, to make sure people were receiving care while risking themselves, I think was fantastic. So our response wasn't a whole lot different than everybody else. I think we all rallied around trying to support our providers, trying to make sure that our patients and members receive the care. One of the biggest aspects of our response was the telemedicine. And, since the beginning of the year, we've done about 3.2 million telehealth visits in our provider offices, peaking at around 60,000 a month back in April. And so, we really did respond, trying to make sure patients got the care they needed through telemedicine visits, through website visits. We also were able to set up a command center similar to what United did as well, where we set up a provider call line, whatever they needed. If we could supply PPE, if we could supply certain things, we would definitely do that. The unique thing too is with our bold goal work, and as ingrained as we are in the community, we were able to connect a lot of our provider groups directly to food resources. One of the biggest challenges was food banks were shut down. And the food banks were shut down. The patients that typically would go to the food banks to get food were unable to. So we worked at supporting, feeding Northeast Florida, feeding Tampa Bay, Second Harvest across the country, where we could deliver food directly to members to make sure that they were taken care of. We were working with the pharmacists to make sure that we could waive costs and get those early refills set up so that the patients can maintain their prescription and their regimen on that. And so, I think we all did a fantastic job as payers, supporting our providers, making sure the members were taken care of, and that working together, that collaboration really is something that I think will carry forward through this to help make sure that we're supporting our providers and our members. Thank you.
Thanks, Paul. Brookings came out with an article. You mentioned food insecurity. Since April of this year, the families, 5% of families were experiencing food insecurity. And since April, that has jumped up to almost 18% nationally. And I wish we had more time to talk about that, but that's quite a stunning example of what you're talking about there, Paul. So hats off to you for looking at that. Azalea?
Hi there. Well, good morning, and thank you for having me. I think as a representative for Blue Cross North Carolina, my hope would be to highlight some North Carolina specific things that we did, but it'll really build on kind of all the wonderful process that have preceded me. My sister is a physician in Florida, so I have it is in my heart today speaking to you. But I would say that early on in North Carolina, we realized that the best way we could support our members was to really put our muscle in supporting providers, the clinicians, practices, health systems. There are 4 major things that we did. The first was the Right to Value program, which was intended to stabilize independent primary care in the state. And so, as Michael noted, the kind of early phase of the pandemic, there was a dramatic depression in revenue, financial distress, and 25% actually of our independent practices serve rural North Carolina. So this is a very critical access, and we wanted to keep these open for our members. So the Salary to Value program was created and launched over the summer as a revenue guarantee program. What we did was try to keep these independent practices that would join the program at their 2019 revenue levels. And what we did is we would estimate the average practices revenue in 2019 and provide an upfront PMPM payment to practices with their attributed members to kind of keep the revenue whole through both 2020 and then again offer catch-up payments in 2021. And the hope was that through this system we could help them weather volatility that was ahead. We also used it as an opportunity to kind of get more practices onto the glide path to value-based care. So our marquee value-based contracting program is called Blue Premier. It already includes 8 of the largest health systems in the state, and over 140 independent practices, as well as some advanced primary care practices as well. But through Accelerate to Value, independent practices working with Allidaid or with some of our FCINs are going to be joining Blue Premier in 21. We do think that this will be a more reliable way for them to be successful in the future. We also let them know that in 2022 we would try to launch a transportation program. The second thing we did was similar to others, is about telehealth, paying attention to video and telephonic. I would just say that the timing of it, we announced at the beginning of March, and as a primary care provider for one of the health systems in North Carolina, it was pretty quickly, once Blue Cross signaled that that's what our plan was, that the workflow really opened up for me. And I suddenly was able to access a lot of the different functionality to really use a telehealth virtual approach to manage my panel. And third, and Ruth mentioned this, how we flipped the script on how we talk to providers. And so we also had the weekly webinars. The first one we clocked in over 600 attendees, and I thought Zoom was going to crash because it was just way more than we had thought. And every week, over 1,000 providers over time were engaging with our digital tools as well as our webinars. And we also took to social media and realized that a lot of, especially generation providers, kind of using that as sources of information during COVID. So my favorite campaign was around the line was, "Hey providers," or "Hey clinicians, we're paying for telehealth, do it now." And that one was a huge success, high engagement rates, and we hope that based on the traffic we saw to our website, was really ways for getting in front of the eyeballs of really busy providers during the pandemic. And the last is around PPE, and everyone has really highlighted that. Maybe some of the North Carolina specific things we did. We invested in 3D printing and injection molding for face shields, so working with local innovators to be able to make low-cost local sources of face shields. And then we took the next step of creating N95 completely locally as well. So North Carolina State University has a wonderful non-wovens institute to create all the fabrics, but there weren't any machines to mold them into N95s. And so we procured 2 machines from China, got them to North Carolina, and working with our medical society and our hospital association, our health systems around testing and fit testing, we're able to now have a local supply chain of 2 million masks a year for our frontline workers. And so I would say that the COVID pandemic really gave us the opportunity to just think differently.
Okay, thank you. As we move to question number 2, we're getting a little background noise and even a little bit of an echo. So if you would, when you're not talking, put your mic on mute, and maybe that will help. I know that I can see that our recording data team has tried to fix that background noise, but I'm not sure that it's they're able to do it. But thank you so much. Let's get right into question number 2. Since March of 2020 and over the last 8 months, payers and providers have experienced abrupt shutdown, as Dr. Howell had mentioned, in clinical care to gradually increasing reopening of services to varying degrees of normal. What strategies and implementations have you focused on with your provider partner that has changed and will have an impact on clinical performance going forward? Dr. Howell?
Thanks, Larry. So when we addressed this, when we realized that our policies and practices needed to reflect the new environment. The way we were doing business really didn't apply in the current and the going forward. And in one of those areas in our value-based programs, we needed to pivot from just looking at the financial aspect of it, and we turned completely around and said, we're going to focus on access. And we've then retooled our ACO program to focus primarily on access. We wanted to make sure that if you had COVID, had a chronic condition, needed preventive health, needed to get into the office, needed to see a specialist, all the things we just talked about, from virtual medicine to relaxing the policies, we've had to make sure that that was available. Now, I will tell you, pivoting from a cost-based ACO environment to an access-based ACO environment was a total shock for a lot of people. But what we did to ease some of that was we promised and made put into effect an arrangement so that we kept their PPM payment for the work they were doing whole. We said, we're not going to put your work at risk throughout 2021. So whatever we're giving you now, we're going to go ahead and lock that in for 2021 so you can focus on the business of taking care of patients. That's worked out very well. We've also made sure that we integrated some newer technologies. We added real-time benefit check. We made sure that when folks went to the pharmacy, our customers went to the pharmacy, they only had to go once. So we instituted use of e-prescribing to make sure that you when you got to the pharmacy, you didn't have to go back to the doctor's office or make an excess trip because the prescription wasn't right or it wasn't on the formulary. We also added metric that looked at health disparities and social determinants of health. I heard one of my colleagues mention that as well. Food insecurity, one of the key items that folks had to struggle with and are still struggling with now during this pandemic. So we added those, and we asked our ACO colleagues to create strategies to start to address that. If there were health disparities in their communities, if there were social determinants of health that needed to be addressed, let's go ahead and do that. And the final thing that we did too in this environment, we also asked our ACO partners to look at medical neighborhoods. Who are the doctors, facilities, services that are really doing a great job? And how can we make sure that you continue to support them? Because this is the best time to make sure we implement efficiencies in the system and take out a lot of the inefficiencies. And that's going to be a tough conversation when you have ingrained, built-in inefficiencies in healthcare. So we're using a lot of what we're going forward with, or what we're doing going forward, to make sure we address some of those. Thanks.
Thank you, Dr. Howell. Ruth?
So as Michael indicated, and I'll just kind of paraphrase, we really wanted to be easier to work with is really what it boiled down to. We needed to be able to facilitate very instantaneous communications. And then the other thing that I wanted to bring forward is cash flow was a huge issue. In the early stages, we actually expedited payment to providers, and we've also developed what we call an acceleration prospective payment program, which allows us to invest in physician group relationships with a reciprocal ask of interoperability around total cost of care performance. So we're moving forward with specific physician groups seeking connectivity with their EMR, EHR, and also asking them to adopt our program called Point of Care Assist, which is around providing insights on members, and also implementing the exchange of data, CCDs, et cetera, and providing them again with reports on members. So one of the things that that we've done as far as strategies and implementation, is around enhanced interoperability. We want them to we want to be able to do some prepayments to them in order to stabilize their practices. And we believe that this approach will allow providers to get more experience in managing population and also around total cost of care, with less fear. So it's a genuine opportunity for us to invest and help offset, the additional costs that that providers experience when they get into, some of these innovative approaches and programs. So we're looking forward to the things that have changed and expanding upon them, as we get into 2021 and beyond. Thank you.
Thank you, Ruth. Michelle?
Yeah, so it's such a great question because of all the dynamics that we're all facing. I think the basic strategy is the same, which is to remain caring, connected, and convenient for our membership, but that also applies to the providers. As Ruth was talking about, the administrative burdens and all, anything we can do to reduce those is sure welcomed. I think that the other thing that's super important is that we see the PCP in particular as the quarterback, of course, for the patient's care, and we see our role as a complement. How can we complement and support and supplement the care plans that you as a provider are instituting for your patients? And that could be through the pharmacists at our CVS pharmacies. It could be through our nurse practitioners in our clinics. It could be through our own case management team. How can we support and do that even better? And for our Medicare Advantage providers, we have talked with them about making some tweaks on our financial reconciliation models to more closely align with CMS benchmarks that are coming out to help alleviate some of those concerns. We're also doubling down on mental health services, and we're all focusing a lot on our senior populations and those, of course, trying to go back to work, and telehealth, and those who are hospitalized. But we're also focusing on that cohort of patients between 18 and 24. And if you think about that population, you know, they're sometimes overlooked in some ways, but when you think about it, that is the age that is already experiencing typically a major transition in their lives. Typically, they're leaving home, either going to college or working. And, you know, right now, they're one of the most impacted age groups right now. So we're trying to really look at as many possible ways to impact and help those with mental health conditions during these times, working with our providers to really do that. As we've already mentioned a couple times, telehealth opens up many avenues to really focus our strategy. I mean, for a number of types of providers, this is applicable, whether you're PCP or specialist. We know that nothing can replace in-person visits when the time is there, but I personally used it myself, and you know what? There is no going back because it is easy. You click on the text and there you are, and you didn't have to drive in. And, you know, for providers, it is a little bit of relief administratively. You know, they're not using as many supplies in their exam room. So it's not going to ever fully replace the need for inpatient visits, but I think we can all recognize it has been a very helpful and appropriate at times support to stay in touch and staying engaged with providers, helping them to remain adherent. I mean, we have to increase the points of access for our patients. So any strategies around those things, closing gaps in care, getting patients in for the services they need, that remains, but it's just been exponentially highlighted during these trying times.
Thank you, Michelle. Paul?
So I think this is great to just hear everybody. I think we're all in alignment, right? We're all doing the same types of things. How do we support the providers? How do we make it easier for the providers to do business with us, right? And then how do we help the patients and the members to be able to get access? So, you know, the telemedicine obviously was a very big component of our strategy moving forward. A lot of the interoperability, right? So how to connect to the providers to make sure we're data sharing, to make sure we're you know, getting the information to the members, to the providers, and those type of things. So I think it's really exciting, the work that we've done around social determinants of health with the bold goal for the past 7 years almost gave us a heads up and a leg up on starting this. And so we're working really closely with our provider offices to start screening for social determinants of health. And Michelle brought up mental health and behavioral health. One of the things we really saw with the shutdowns was, you know, major issues around seniors and others in loneliness and isolation, leading to depression, leading to suicide, leading to opioid addiction and alcoholism and you know, domestic violence. And so really starting to screen people for those type of things and working with the providers to help them identify interventions within communities. One of the cool things we did is we partnered with a company called Older Adults Technology Service. And through our Humana Foundation, which is our philanthropic arm, we gave $3 million to OATS. And really that helps to connect seniors, make sure that they've got connection to the internet, they know how to use technology, and they can start to connect a little bit better. And so it's adults, you know, seniors teaching seniors, and it's really exciting. They're doing some fantastic work. And so we've done some pilot programs in San Antonio and Texas and other parts of the country, you know, eventually moving them down here. But I think this, you know, the bold goal, being able to look at new and different ways to treat patients and members and providers really is giving us a different lens into supporting people as we're moving forward.
Excellent, Paul. Dr. Kim?
A lot of my comments build on the amazing work that everyone has already showcased. I would just say that the two specific, and it ended up timing with COVID, but we had been already working with a Silicon Valley firm called Nuna to launch what we call the value platform, which to a point that I think Ruth made earlier around the value of data in this area, especially when we can't necessarily be closer with our providers, be able to show them what we're seeing and ways that they can potentially better help our members during this time. That platform was launched over the summer, and it allows them to have a kind of more refreshed and real-time look at the data analytics that we're seeing about our population and where we can potentially support outcomes. And to build on a point from Michelle, we also have, it kind of dovetailed really nicely in this period of time around our investments in behavioral health. And so in addition to the, as a plan, integrating behavioral health and moving towards whole person health, we've been working with two organizations, Quartet, as well as Eleanor. Quartet providing our primary care providers throughout North Carolina the opportunity to engage in the collaborative care model in a meaningful way. Both the technology as well as the ability to identify behavioral health providers that would work with folks like me on the primary care side to really provide the kind of care that our patients need right now. And then Eleanor Health to kind of fill the gaps in our substance abuse treatment and addiction treatment programs at the state. So this is work that preceded, but it was accelerated during COVID. How do we work with our provider systems to both help them get the information they need and also shore up the teams that they need to deliver the best care possible?
Thank you. Excellent. Yeah, moving on to question number 3. And again, we're running a little tight on time, and I want to make sure that we get to question number 4 as well. So if you could be a little brief, but certainly explain what you want to say. How has COVID advanced or inhibited all the hard work that we've done in value-based care in the movement? How can providers and payers position themselves to improve upon pre-COVID value-based care models and all the movement that we've made moving forward? Michelle, how about you taking that first?
Sure, I'll be happy to. So in my view, it's definitely advanced the cause for value-based care. Now, of course, there's a continuum, right? But I think that those, for example, here in capitation models, have been able to see the biggest benefit from that. Obviously, they have that steadier stream of income, and just generally speaking, honestly, our value-based providers tend to be the most, right? They're more into technology. They realize the benefits of digital. They're really more on the cutting edge. And also, due to our complementary efforts, have more data access. Right? You understand more about what's going on with your patients. You're able to look at patterns. You're also able to think about alternative or more omni-channel ways of engaging your patients. Because, at the end of the day, what matters is quality, efficiency, and patient satisfaction. And I believe all clinicians are focused on that, but those who are in value-based arrangements usually have more tools. They're more ready to launch onto new ideas and do things differently. The whole thing around social determinants of health, that is definitely a soapbox I could get on for a couple of hours. I mean, it's always been around, but this time especially, and I'm just amazed it's kind of taking us as an industry. It took us a while to kind of really jump on the wagon and realize that 10% of our healthcare impact is from clinical care, and 70% is lifestyle choices and social economic conditions. And a patient doesn't have a house or a car or someone to support them, and they don't have food in the fridge, then how could they possibly be on their best journey of health, right? So we're all wrapped around that now, and I think our value-based providers are right at the forefront of that, working with community organizations. So I definitely think that we're there to break down the barriers, and we're definitely more on the forefront. And the more that we can progress, frankly, over time to more capitated models where you can really focus on that and not have to have as much anxiety over the financial pieces, I think that could be more of an ideal state for most of us.
Great. Dr. Howell?
Yeah, I love everything Michelle just said. And I will tell you that what I would add to that is the downside. It took our eye off the cost equation. The reality of it is we can't take our eye off the cost of healthcare because it continues to rise, and there are millions upon millions of Americans that just can't afford it. The other thing that I would add, and she alluded to this as well, is that it really focused our vision on the other aspects of care. We didn't pay a lot of attention to health disparities, social determinants of health. We didn't pay a lot of attention to behavioral health issues, but a lot of us, I'm hearing everyone say the same thing. We've all are pivoting or have pivoted to bring those into the forefront of the equation. And while we keep costs in there, we've got to bring those other pieces in because those are probably the determinants that keep our costs high in the beginning anyway. Thanks.
Okay. Thank you, Dr. Kyle. Ruth?
Yes, so value-based care continues to be important for us. However, COVID did have an impact, particularly with preventive screenings. I actually, a month or so ago, I asked our actuaries to provide me with some data on breast cancer screening. And from mid-March to mid-May, there was actually a 74% reduction in breast cancer screening. Good news is that when you look mid-May to mid-August, it actually was only a 12% reduction. So there was some improvement. So really bottom line is that what we've seen in our relationships here is that innovation sprung forward. We saw some of our ACOs with an increased use of Cologuard for colorectal screening. As you know, that's a stool-based test that can be done at home. Good news is there's no special prep for it, and also, a patient doesn't have to stop their medication prior to collecting the sample. So we saw, an improved use of that, which was good. We were now folks were continuing to close gaps in care. We've all talked about telehealth, but I would say that my main message here, as it relates to positioning themselves to improve in value-based care models, is embrace the change as technology involves in the implementation of additional products that allow providers to diagnose and treat certain ailments, such that they would do via video visits. So envision a pillow that can track your temperature. You're a parent, you wake up and you can see that your child has a fever. You're not going to wake them up to go to school, but you do need to understand what their other symptoms are: sore throat, earache, etc. Once you do, you call the pediatrician and you conduct a video visit. So what I'm outlining there, is it will happen. It's just a matter of time. And so, providers need to embrace technology. We have EKGs now via Apple Watch. You can also do home eye exams. We're just touching the surface, and COVID has actually propelled us into into these new technologies. So embrace them, be prepared for a significant change. And I think I said this 2 years ago, and I'll say it again: stop building bricks and mortar and buildings, because care will be delivered in a much different fashion on a going forward basis.
Thank you, Ruth. Dr. Kim, your thoughts on question number 3?
Yes, so I would just say that I think that it's accelerated value-based care and just seeing the appetite for it. So our Accelerated Value program that I mentioned before, 530 practices signed up for it. We have 270,000 new members now attributed to a provider accountable for quality and cost, and that would not have been the case probably in any other different scenario. And it's also great to see the appetite for information that's beyond just the clinical data and claims, but to think about behavioral health, social drivers of health needs, and this appetite to understand health inequity in North Carolina. And that is just so great. I think as a clinician, particularly, I think there's just still a ways to go. And I'll also be a little bit of a data geek here of like, I don't know at this stage what is still really a truly necessary feature, or what is a downstream form of deferred care for things that kind of had just been the usual way of my practice is configured to manage a certain set of patients. And I think there's a bit of an analytics question there of the low tech and high tech ways that I've worked around taking care of my patients, and if they've been successful, how do we know they were successful, and how can we make them persist? I think that is a little bit of my question. If we don't get that answer soon enough, will we flip back into old ways?
Okay. Paul, your thoughts?
So I think it's obviously advancing value-based care. I think, being able to provide that stability at a provider office, it allowed a lot of our provider groups to be very nimble as this came around. I mentioned earlier about food deliveries. We had multiple instances of provider groups being able to support nonprofit partners to actually donate vans to deliver food to people in communities. And so working, tightly with our food bank partners to identify zip codes where we needed to get food to patients. And it wasn't just our patients, right? It was the entire community. And so we've got lots of, examples of that. Getting providers across the spectrum. So specialists and primary care to work together a little bit more and integrate, I think was a big part of this as well. And so it's been exciting to see, yeah, I think it was Dr. Kim earlier talked about whole person health, and we talk about human care, right? And it's looking at that 60, 70% of the things that happen in the community that can't be affected by the doctor's office, and allowing the physician to know where it is, through data and analytics, but then also working together with them to identify community partners where we could really make a difference.
Excellent, Paul. It's interesting listening to the five of you. While each payer has a proprietary program, it's interesting that so many things you all are focusing on the same challenges and the same things that you want to get done, particularly in the areas of social determinants of health, which I think we could talk about all day. Let's move on to the last question. One of the challenges of the coronavirus pandemic has been a reduction in healthcare spend due to stay-at-home requirements and business closures or slowdowns and all the things that you guys have already talked about to prevent the spread of the virus. Healthcare payers benefited from the reduced spending in healthcare with increased profit margins. As the U.S. evolves through the stages of the continuing pandemic, how will those profits be used to rebalance medical loss ratios to required levels under the Accountable Care Act? I'm going to mix it up a little bit. Dr. Kim, if you would start that off.
Sure. So as representative from an insurer, I don't have the insight into the financial of any given hospital or health system, but I would say that Blue Cross North Carolina's one of our greatest goal or highest calling is around affordability, and it's something that we actively track, that all of our executives are responsible for. So we've been able to lower our average premiums last 3 years in a row in North Carolina, and as more recently we're able to take our estimated MLR rebate prior years and channel into it $200 million worth of health and wellness cards for the 600,000 eligible members, which I believe is particularly helpful to them. But I would just say that affordability has always been stressed, and it's actually the reason value-based care is so important to us, is we do believe that it is in order to drive affordability in North Carolina.
Excellent. Ruth?
So the health of our members and the safety of those that we serve are really our top priorities. And United is providing over 1.5 billion of support to our customers in various fashions. We did credits ranging from 5 to 20%, depending on the specific plan that was applied to their premium. For our members that are covered under our Medicare Advantage plans, we waived cost sharing to specialist and primary care physicians. We also did cost sharing and waiving for COVID testing and the test related visits. We expanded telehealth access, which we've already talked about. In addition, we also did, we've done a lot in the expansion of member resources. We have a COVID-19 information hub for both our members as well as providers that provides up-to-date information and support to our members, including how to talk to your children about COVID-19, how to access care, understand their changes in benefits. And then also, in addition to that, we've introduced a COVID-19 symptom checker that they can go out and review their symptoms quickly. We've provided an online tool for them to be able to understand and find a COVID-19 testing location. We've also, we offered early prescription refills. One other thing that we did, which I think was very helpful for individuals as you look to, understand how to reallocate dollars, is we actually did a special enrollment period too. So we opened that up as a one-time benefit for those employees that hadn't opted into coverage during their regular enrollment period. We opened it up and had a special enrollment period. We allowed a grace period for people to pay their premiums. I think I already mentioned that we had accelerated payments to providers. Some of the other things that we've done is we've launched what we call Protect Well, which is an innovation return to workplace protocol that enables an employer to bring employees back to work in a safe environment. We also dedicated one of our senior executives, Sir Andrew Whitty, who is the president of United Health Group and CEO of Optum, to co-lead the global effort of the World Health Organization. We paid out 23.8 million in nationwide employee programs that covered the cost of emergency care for kids aged 12 and under. Similarly to Paul's comment, we organized our cafeteria and food service teams to make meals available for those in need. We did over 75,000 meals per week in Minneapolis, St. Paul, Greensboro, Hartford, and Las Vegas, where we had cafeteria availability. We've deployed many of our clinicians to man telehealth lines. So we've actually, the dollars that that were accumulated, we've actually redeployed them in many fashions to support the healthcare system, to support our members, and also have done multitudinous donations, some to the American Nursing Foundation and the CDC Foundation, $3 million. We've also done over 12 million in health grants. So we're just really just taking those dollars and redeploying them in an effort to support the communities and the members of which we serve.
Thank you, Ruth. Paul?
So I'm going to say it. I'm really excited to hear that we're all kind of doing very similar things, right? As we really are looking at ways to support our providers, support our members, and so, we have done a lot of investing in new technologies and interoperability, right? And the ability to connect with our providers more, our patients more, enhanced benefits to make sure that we're addressing social determinants of health. So food benefit cards and things like that are going to be better for the members as they move forward. And our Humana Foundation, Humana gave $150 million to the Humana Foundation, and each of our 16 bold goal markets got a good chunk of money to work with community foundations, community partners, to really find those trusted entities that are doing work in the community to make sure food is there, to make sure mental health resources. One of the things that I also lead the Tampa Bold Goal. We worked with the Community Foundation of Tampa Bay, Love for Lawrence, St. Petersburg College, and several others. And we're going to help, or we are developing a program to train 5,000 mental health first aid trainers across Tampa Bay. And that's going to help to, raise awareness around mental health challenges, give people the ability to talk about mental health. So there's a lot of things that we're doing, within the communities, but also probably way more things at the corporate level that I'm not a part of, that we're doing to provide our, to work with our providers and make it easier for them to work with us and care for the members. So thank you very much, Larry. I appreciate you guys asking me to join this panel.
Well, thank you, Paul. Michelle?
Yeah, this is super exciting. I just love hearing all the things that we're doing, and it just kind of underscores that we're all, in it together. We have the same vision. We're here to help promote health for individuals and groups and people. So it really is wonderful. I have a few things that I'm really excited to share about some of our investments, but before I do that, I'll kind of take a moment to state the obvious, which is the story isn't over regarding healthcare utilization, right? So I think we're all waiting, providers, hospitals, physicians, payers, everybody. We're all waiting to see how this story continues to unfold. So while obviously there was a huge reduction in utilization, many predicted that in the summer we were going to have this huge resurgence, and of course that didn't happen to that degree, although we are seeing care gradually return. But then here we are, entering flu season and watching the numbers in 49 states, cases go up again. And so it really is a story that is still unfolding. We're all doing our best to predict, how this is all going to turn out, but we really still don't know. If we're all really honest, we still don't know how this is going to unfold. We don't know how COVID-19 costs themselves are going to impact things. I mean, we're still watching, waiting, and doing our best around business planning and operating models to manage and do the right thing. Some of the things I'm really, really excited that we are doing is we have made the decision to invest $600 million over the next 5 years in working in local communities to address healthcare disparities that have been so highlighted during this past year that were already apparent and already there. But we're doing that. We just announced that locally here in Orlando over the past week. Yes. An effort launched there, and we're in a really great position, obviously with testing, right? So we have over 4,000 testing sites across the country. We've administered 6 million tests through our CVS retail locations. We're the top provider of being able to administer tests. 70% of all retail testing we've had the privilege to be able to be a part of. Some of the other things that we are investing in are chronic disease programs, putting a lot of focus on diabetes, behavioral health, oncology, and other mental health services. And another thing that we've been really excited to do working with some of our plan sponsor clients is the Ready to Work program. So we've been able to go on site and help do testing for employees and help them get ready to integrate back when we all feel comfortable doing so in greater numbers back into the office setting. Another thing that's been really rewarding is the Caring for You kit that we've mailed to all our Medicare patients. And that has been so rewarding just to see them excited to get these kits that are made for them. They contain all these really practical items from some of our stores and other things to really help them manage the ways they need to stay safe and healthy during these trying times. So, a number of items that we've invested in that will continue to move forward and are excited about. Thank you.
Michelle. Dr. Howell?
Yeah, thanks, Larry. So, about a decade ago, the health plans and payers really could have kept a lot of those profits, but under the Affordable Care Act, there's a medical loss ratio that has to be met. So I would have expected when we shut down and closed everything off that there would have been excess dollars. But as everyone has already pointed out, that curve dipped. That curve is now on the rise again. And in many cases, I've talked to physicians where they're back at 90-95% capacity seeing patients in the office again. Ambulatory surgeries and elective procedures, all those things that were put on hold and that didn't cost money then in the early stage, now are back on the books and being performed. So those dollars aren't being spent. I won't reiterate what everyone said about what they're doing, because what you're hearing is that folks are putting those dollars right back into the communities. They're giving those dollars right back to the employers as discounts to make sure that insurance remains affordable for everyone. So I think that, the thought that's out there or the reports out there that these huge profits, yes, but they were there only because services weren't being used. Now those services are being used, those dollars are going in the right direction. A couple things I would point out that Cigna has done, launched Express Scripts Parachute program, Parachute RX, that ensures that every American that might have lost their health care benefits as a result of the COVID pandemic can get their medications at predictable prices. We're really proud of the Cigna Foundation and New York Life Foundation launching the Brave of Heart Fund, which provides monetary grants to survivors of frontline U.S. healthcare workers who gave their lives in the fight against COVID-19. So again, using those dollars in a positive manner. Cigna and Express Scripts launched a free web-based interactive triage program in collaboration with Bowie Health, to allow better assessment of COVID-19 risk. And the last one I'd point out is and we've all talked about it, making sure that we provide services for behavioral health concerns, whether it's loneliness, I've heard depression, I've heard anxiety, I've heard increased suicide. So putting those dollars back into play, has always been our plan. That hasn't changed from our baseline principle and our goals. So I think what's called profits really were dollars that just weren't spent. Those dollars are being reused now or put back into circulation, taking care of the very people that we've all promised to take care of. Thanks.
Excellent. What an incredible discussion, informative, insightful. And I can't thank all of you enough that you took your time to share what you 5 major payers in this country are doing, not only during the pandemic, but to advance value-based care. And if you guys would all stay on for a minute, you'll hear a prompt. And again, after the recording, I believe it's at 2:15 on the 19th, Thursday, November 19th. And after that, we will have an open panel. And any of you that can participate in that, we will have a question and answer period that will not be recorded. It would be live. But thank you again so much. As a Flacos board member, it means the world to our organization for you guys to participate in such an informative discussion. So thank you so much.
Thank you, Larry.
Thank you for having us.